Good morning. My name is Dr. Kejal Shah, and I am currently a PGY2 internal medicine resident at Texas Tech University of Health Sciences at the Permian Basin in Odessa, Texas. Today I'll be presenting a case of allopurinol hypersensitivity with concomitant erythrodermic plaque psoriasis. Allopurinol, a xanthine oxidase inhibitor, is commonly used to manage gout, tumor lysis syndrome, and symptomatic hyperuricemia, and is generally well tolerated. However, it is associated with a variety of delayed hypersensitivity reactions known as allopurinol hypersensitivity syndrome, and is one of the most common causes of severe cutaneous adverse reactions, called SCAR. Erythrodermic psoriasis is an uncommon severe variant of psoriasis that is characterized by widespread confluent erythema of the skin. We report an interesting case of concomitant allopurinol hypersensitivity and erythrodermic plaque psoriasis that has not been reported before. 37-year-old Korean male with medical history significant for hypertension, gout, and stage 4 chronic kidney disease with baseline creatinine of 2.1 and no prior history of dermatitis, presented with 2-week history of progressively worsening diffuse pruritic rash and diarrhea. He recalled a gout flare 5 weeks prior that was treated with allopurinol and colchicine. Initial vitals were stable and physical exam revealed a generalized erythematous maculopapular rash and oral ulcers. Lab values of concern included leukocytosis without eosinophilia, lactic acidosis, AKI with creatinine of 6.9, transaminitis, and elevated creatinine kinase with rhabdomyolysis as evidenced by the absence of RBCs but staining for large amounts of blood on urine analysis. No eosinophils were seen on urine analysis. All immunological workup, including ANA and complement, were normal. Interestingly, the HLA-B5801 was positive. He was initially treated with dexamethasone and empiric antibiotics for possible sepsis, which were then discontinued as all cultures remained negative. He was treated for presumed drug-induced rash with high-dose oral prednisone for 1 week. Over the course of the following days, however, the rash was progressively and diffusely desquamating. Hence, a punch biopsy of the skin was done, which revealed spongiosis, that is localized epidermal swelling, acanthosis, that is thickening of the epidermis, and a few necrotic keratinocytes, findings that were not specific. Renal biopsy showed acute on chronic tubulointerstitial nephritis, global and focal segmented glomerulosclerosis, and interstitial fibrosis. Due to worsening renal function, he required temporary hemodialysis during the hospital stay. Over the following 2 weeks, he showed considerable improvement and was advised against the use of allopurinol or febuxostat. Interestingly, on OPD follow-up, he had a relapse of his rash with silvery scaly plaques seen on his elbows while on the steroid taper. He was then treated with adalimumab for erythrodermic plaque psoriasis, which is a recombinant monoclonal antibody that binds to TNF-alpha. He returned to baseline within 1 month of treatment. Erythrodermic psoriasis is an uncommon severe variant of psoriasis and is often triggered by medications, systemic steroids, infections, or stress. Although plausible that the maculopapular rash with diffuse erythroderma were caused by allopurinol, in which case we should be cognizant of this presentation, erythrodermic psoriasis may have been triggered by the steroids, signaling the need to be cautious while prescribing high-dose steroids. Since skin biopsy did not indicate psoriasis and he did not report a history of psoriasis, he was treated with high-dose steroids. Additionally, HLA-B5801 allele is strongly associated with SCAR during treatment with allopurinol and is most common among Asian subpopulations, notably in individuals of Korean, Han Chinese, and Thai descent.